بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. I'll talk about the rhinitis. Rhinitis is an inflammation of the nasal lining. This condition is very common. Approximately 1 in 6 adults suffer from rhinitis. Symptoms of rhinitis are nasal obstruction, rhinorrhea including postnasal drip, sneezing and itching, hyposmia and anosmia, facial pain and headache. Causes of rhinitis. There are many factors which cause rhinitis. The commonest forms of rhinitis are allergic and infective. The symptoms of rhinitis may be of systemic disease. Rhinitis as part of systemic disease. Primary mucus defect like cystic fibrosis and Young syndrome. Primary ciliary dyskinesia as in Cartagener syndrome. Immunological like SLE, rheumatoid arthritis, AIDS, and antibody deficiency. Granulomatous disease like Wegener's granuloma and sarcoidosis. And hormonal like hypothyroidism and pregnancy. Rhinitis can be classified into allergic, infective, and others. The allergic rhinitis is subdivided into intermittent or seasonal allergic rhinitis and persistent or perennial allergic rhinitis. And the infective one subdivided into acute and chronic, and the chronic divided into specific and non-specific rhinitis. The other types of rhinitis are occupational, nurse non-allergic rhinitis with eosinophilia syndrome, hormonal, drug-induced, irritants, food, emotional, atrophic rhinitis, and rhinitis associated with a GERD and idiopathic or vasomotor rhinitis. Simple acute infective rhinitis. This is well known to all of us as the nasal effects of the common cold. It is usually viral in origin, spread by droplet transmission, and it is a self-limiting disease. Allergic rhinitis is an IgE-mediated type 1 hypersensitivity reaction in the mucous membranes of the nasal airways. It can be either seasonal allergic rhinitis, also called hay fever or pollinosis. The link with the hay came about due to an early incorrect theory that the symptoms were brought about by the smell of new hay. Hay fever is a misnomer. Why? Because there is no association between allergic rhinitis and hay. And there is no fever in allergic rhinitis. The perennial allergic rhinitis, sometimes associated with seasonal exacerbations. In seasonal allergic rhinitis, the allergens are inhaled in the form of pollen, grass, and weeds, while the allergens in perennial allergic rhinitis either inhaled in the form of house dust, dust mite, animal fodder, and feeders, and the ingested allergens like wheat, eggs, milk, and nuts. This picture shows the pollens, and the diameter of pollen is about 20 micrometers. And this picture shows the dust mites, and the diameter of dust mite about 200 micrometers. This is another picture of dust mite, and the dust mite is the causative agent in persistent or perennial allergic rhinitis. The pathogenesis of allergic rhinitis in genetically predisposed individual or atopic patient when exposed to the inhaled allergen there is IgE production, and the IgE binds to the basophil and mast cells by its Fc end. On subsequent exposure to the same allergen, the allergen binds to Fab fragment of IgE on the surface of mast cells, and this antigen antibody reaction over the surface of the mast cells causes destruction and degranulation of the mast cells with the release of chemical mediators, either preformed or newly synthesized mediators, and the most common mediators of allergic rhinitis are histamine, leukotrienes, and cytokines. So, if the atopic patient exposed to the allergen at the first time, there is an IgE production, and the IgE bind by its Fc fragment to the mast cell. On subsequent exposure to the same allergen, the allergen will bind to the Fab fragment of the IgE on the surface of the mast cells. And this binding between the allergen and the IgE on the surface of the mast cell causes degranulation and destruction of the mast cells with the release of the chemical mediators like the histamine, leukotrienes, and cytokines. We have two phases of the allergic response in allergic rhinitis. The early phase, which occurs within minutes after the exposure to the allergen, and the mediators are the histamine, leukotrienes, and the symptom of this early phase are sneezing, nasal itching, rhinorrhea, and nasal obstruction. While the late phase of allergic rhinitis, which occurs 4 hours and more after exposure to the allergen, the mediators are cytokines and leukotrienes, and the symptom is prolonged nasal obstruction. The clinical features of allergic rhinitis are rhinorrhea, sneezing, congestion, postnasal drip, itchy nose, snoring, staxis, sinus symptoms, cough, throat clearing, associated with itchy, watery, red eyes. During examination of patient with allergic rhinitis, we can see the allergic crease, horizontal crease line at the dorsum of the nose between the cartilaginous and the bony parts due to frequent rubbing of the nose. And the appearance of the patient during frequent rubbing is called allergic salute. This is the allergic salute. The patient with allergic rhinitis also has atopic dermatitis or conjunctivitis, and the allergic nasal mucosa is usually bilaterally swollen, pale, or bluish in color, with the edema of the mucosa and the mucosa covered with watery secretions. Examination of the chest with measurement of pulmonary function may be needed, and this is allergic salute and the allergic shiners and any Morgan Falls horizontal crease line of the lower eyelids and pale edematous mucosa of the nasal cavity. This is the typical appearance of nasal mucosa in patient with allergic rhinitis. There is a pale edematous mucosa, hypertrophy of the inferior turbinate, and watery rhinorrhea. Allergic rhinitis usually associated with certain disorders like nasal polyps, sinusitis, bronchial asthma, and chronic obstructive airway disease, recurrent upper respiratory tract infection, snoring and obstructive sleep apnea, allergic conjunctivitis, otitis media with effusion. Investigations of allergic rhinitis. Most allergic rhinitis patients can be diagnosed by a combination of history, examination, and investigations like: number 1, skin prick test. The allergen introduced into the skin causes degranulation of IgE sensitized mast cells with the release of mediators like the histamine and formation of a wheal and flare in the form of a small raised red itchy patch. The skin prick test is simple, cheap, and safe. Positive skin prick test means that the patient is sensitized to that allergen. This is the skin prick test. The allergen solution is placed over the skin of the forearm, and we do pricking of the skin by needle. On the positive test, the skin is red and itchy. Positive wheal and flare test. This is another picture of skin prick test using different types of the allergens. And this is a modification of a skin prick test called patch test. Number 2, blood test, like the RAST, radioallergosorbent test, for the assessment of a specific IgE. The RAST should be used where there are contraindications to skin prick test, where skin prick tests are unavailable or difficult to interpret. B, the PRIST, plasma radioimmunosorbent test, for the assessment of the total IgE, and it is less specific than RAST. C, total and differential count. Peripheral eosinophilia may be seen, but is an inconsistent finding. Number 3, nasal smear for eosinophils. An increase of eosinophils in a smear test of nasal smear indicates an allergic rhinitis, but is not diagnostic. Number 4, nasal propagation test. A drop of the suspected allergen squeezed into the nose may cause symptom of rhinorrhea and sneezing. Good luck.